about the mind, body, and soul. Our pastor teaches us that self-care is soul care. So when we take care of ourselves, we really care for our souls as well. So this is part of a series that he teaches on, and this is something our women do on an annual basis. We missed it during COVID, so we have been doing our annual Mind, Body, and Soul Week conference for about 15 years now. And so we're very serious at Rehoboth Saints Center about our health. We are so delighted. We're also partnering with the Mayo Clinic in regards to the Body and Soul Initiative. It's a cancer prevention initiative. And we're just happy to be a part of just the family of Mayo. I just feel like we just, have forged a good relationship. For those of you, if this is your first time attending, welcome. We just appreciate you being here. I'm going to offer up a word of prayer before we get going, and then Blanca's going to come with a raffle, and then I'm going to turn it into the hands of the staff of Mayo Clinic. Father God, we thank you for this day and for this hour. Thank you for once again blessing us to come together just to be a part of this fellowship and this conference, the women and the men who are here. Bless us, oh God, in our efforts, and just give us what it is that we need on today. Give us hearts to receive and minds to believe. In Jesus' name we pray. Thank God. Amen.
Good morning. Thank you for being here. We are recording today, so please make sure you have signed a consent form. If you have not, then please let us know. We'll make sure to offer you one. In each of your seats, you will find a Sonata bag with a journal and an agenda for today. Mayo Clinic is honored today to partner with Rehoboth Saints Center and with the collaborators like the White Dress Project, Sonata Ganasonic, and Hologic to offer you this one-of-a-kind fibroids educational event filled with relevant information, compelling stories, and fun surprises. Mayo Clinic is the largest non-for-profit organization group practice in the world. Our innovation history dates back more than 150 years when brothers Will and Charlie Mayo pioneered an integrated team-based approach to medicine. Today, Mayo Clinic has more #1 rankings than any other hospital, according to the U.S. News and World Report. We have campuses in Minnesota, Arizona, and Florida, a network of regional clinics and hospitals and international locations. We partner with community organizations to end health disparities throughout educational programs, personalized healthcare, and community-engaged research. Behind our top rankings, you'll find a diverse, exclusive culture of teamwork, excellence, mutual respect, and dedication to putting our patients first. Mayo Clinic is determined to solve the world's toughest medical problems, one person at a time. Thank you again for being here. I am going to present, and it is my honor to present to you Tanya Leak. She is a passionate student and teacher of wellness principles. She's a graduate of the Stanford University Industrial Engineering program. After 18 years as a senior business strategy and technology consultant, she left corporate America, dedicating herself full-time to supporting others attain a really nice lifestyle that embodies well. Please give her a warm welcome.
She experienced fibroids. She continues to be on a fibroid journey and a fertility journey due largely to her fibroids. She started the organization in order to find community. And this is really what, as I'm hearing this wellness annual gathering that you have is about, right? It's about you coming together to support one another, but also to provide education and awareness as to the things that may affect your health and well-being. So that's really why Tamika started the White Dress Project. She calls herself a fashionista, and of course she would say, I am a fashionista, I don't call myself that. So she really, one of the symptoms that she experienced was heavy bleeding, and she could not wear white. So the symbol of the white dress is really hope that we can do the things that we want to do, we can be free to be who we want to be, and still manage and be on a fibroid journey. So So we wear white. It is challenging to be on the board and go to events because you have to have a closet full of white. So I don't consider myself a fashionista, so that's why it's a challenge. So we are also committed to breaking the cycle of fibroids. The statistics vary, but generally what we like to say is that based on the statistics, 70 to 80% of women overall will have a fibroid by the time that they're 49. Now they may be symptomatic, they may be asymptomatic, but they will have at least one fibroid. So given that prevalence, right, there is a cycle that's happening. And we really look to break it with education and awareness and events like this, working with the Mayo Clinic. So what we like to say sometimes is fibroids to freedom. So who am I? So as I mentioned, I'm with the White Dress Project. I'm actually the co-director of research. We are a volunteer organization. So if you send me an email and I'll get back to you right away, please forgive me. I'm also a fibroid wellness coach and advocate. I actually have sort of targeted my health and wellness coaching specifically to working with women with fibroids. And that's because of what you'll hear from me later on, which is my story, my journey, my experience with fibroids. So today I want to talk to you about my story. I want to talk to you about some of the lessons that came out of it. It was actually the way in which I got connected to the White Dress Project. And I love that we're talking here at a Mind, Body, Soul event, because part of what I discovered is the importance of really the integrative medicine approach, which the Mayo Clinic follows. And then as a health and wellness coach, I can't leave without us actually doing something towards our health and well-being. All right, so my fibroid story. So I'm going to start with the beginning, but actually I did not think about this until I started talking to people and talking with physicians and researchers. So it was the gush. So with my period, I always had a preview day. That's what I called it. My little spotting day was like, oh, you're in. And there were a couple of months, again, not consecutive, not continuous, that I had this gush. First day, so close, definitely no white dress. That was for me, given my normal cycle, that was a change that I noticed. And at the time, so if you asked me when I was dealing with it, that was before my fibroids started to grow significantly, so to where it was visible, I would have told you I was asymptomatic because I had no other symptoms. So other than that, my period wasn't heavier than usual. It wasn't longer than usual. It was just now I didn't have my preview day. So the gush, and again, looking back, that was a change that should have alerted me to have a conversation with my healthcare provider. So if you experience, so that's the lesson that I took out of it, if you experience a change in your menstrual cycle, symptoms that you, especially that you notice and go, then that's a time to, and an opportunity for you to have a discussion. The second, I'm a health and wellness coach. I've been a health and wellness coach, as was mentioned. I left corporate America. I'm a fitness instructor. I do yoga, all of the things, right? I was like, fibroids, I'll take care of this. I'll just be really, really vigilant about my diet, and so I focused on all the things. Well, my fibroid continued to grow. So I will tell you, it became 16 centimeters, so I was getting the question about whether or not I was pregnant. And again, other than the intermittent gush, I didn't have any of the other common symptoms, no frequent urination, even given the size of the fibroid. And when I tried to do the things, focus on diet, focus on nutrition, I saw a difference if I was being almost monk-like in my approach. So no alcohol, no caffeine, and most of that stuff wasn't even part of my diet, but I had to eliminate it entirely. I did notice that my fibroids would shrink and grow. I could actually see my belly either go down or expand. But I wasn't able to really deal with it in the way that I wanted to. So I actually stumbled upon a blog article called When a Healer Gets Fibroids. And it was really about people in the health and wellness industry that get fibroids. Because I had a sense of guilt. I was supposed to be helping people with their health and well-being, and I couldn't figure out what was happening. I couldn't get control of this through all of the methods that I had been taught would be effective. So this article was talking about the other parts of the health, journey, which include all the things we're talking about here, right? Mind, body, and soul. So it really got me to think about what was happening outside of some of those physical aspects. And the other thing that in the holistic tradition is considered is that, perhaps you can be appreciative that your body has collected, and we'll talk about this in a few moments, some of the experiences, the negative experiences that you've had into this sort of almost as a benign shield that it's created, right? Because fibroids are benign tumors, but it's benign, right? So it is not cancerous. And so as a result, can you be appreciative that it's done that? And then I was actually, it changed my mindset in terms of being able to approach surgery and having it removed, because before that I thought, I need to be able to do the things and make this work. So it allowed me the space to actually take action and deal with my fibroid and have a mindset that was not about guilt. So the lesson I took out of that was it happens. And it is not anything that you can control, but you can take action. So that led me down the path of searching for a doctor. So we actually did a survey, the White Dress Project, last year, and our survey showed that 61% of our respondents, we had 1,000 respondents, saw more than 2 doctors in order to finalize their diagnosis. They actually saw more than 3 doctors on average in order to figure out what they were going to do treatment-wise. So that means that it's not uncommon. I saw 5 doctors before I found a doctor that I felt respected me, talked to me as if I was a person, and heard my needs. I wanted to preserve my uterus. I will tell you, I was 43. And, the first doctor I saw said, okay, well, and I don't have any children by birth. So she said, well, you're not going to have kids. Period, not question mark. And so my journey continued. I'm not going to tell you about all of the 5 doctors that I saw, but my 5th one, I had to breathe a sigh of relief. And I was talking with Jordan earlier, and unfortunately, I think that it is sometimes really frustrating when you voice, I've had a change in my menstrual symptoms. Oh, that's all right, you bleed heavy. If you hear that, move on. Because we need to take it seriously. And there needs to be some follow-up to that, at least a follow-up question, not a dismissal or a statement of what you're going to do. So my lesson from that was, you have the right. And I know it's difficult. One of the things that caused me to actually take longer to find treatment was because I had to find the next doctor. And that was challenging. So I know it's difficult, but use your resources. This community is your resource. The way that I found the 5th doctor that I got to was because I was talking to someone about the challenges that I was experiencing, talking to a friend, and she said, oh, I had a myomectomy, and we never talked about fibroids before. Really? You had fibroids? Yes. She referred me to her doctor, and that was the one. So please use your network. When you talk about it, 70 to 80%, you're going to find out that and that's actually my next thing. When I opened up about it, I actually put a post on Facebook. I was just thrown back by the number of responses I got. people asking me, well, I'm thinking about, I was really taken aback. I probably got on that post 100 responses in the first day. People asking me, what made you decide to do this? And can you connect me with it? I mean, it was amazing. So when you open up, you're not only getting information, you're probably providing someone else with the support and the sort of reinforcement that they need. And then my procedure. So I did wind up getting a minimally invasive, so a laparoscopic myomectomy. And my doctor, so these are just pictures from the procedure, and it was really interesting. So I'm not going to go into all the procedure stuff, but one of the things that I found is that this is another reason to come together in community with others around it. There are some things that they don't tell you about the procedure. Well, actually, I shouldn't say that. Some doctors will tell you, some doctors not. My doctors did not tell me. I was expecting pain post-procedure, but the gas. The gas is the most painful thing. I wasn't ready for that. So I think that, again, you being able to talk to others that have experienced it, and that's what we have at the White Dress Project as well, is a sense of community, so you can talk about some of these things, and you can help others be prepared for the experience. My reset had to do with what I'm going to talk about next, which is, okay, so what am I going to do? Because I'm one of those people, I was a consultant, so when I see a problem, I'm like, how do we fix it? So that's how I got connected to the White Dress Project. I was like, there've got to be some organizations that are doing something about this, because this is a problem. I shouldn't have to go to 5 doctors to find someone that will talk to me, that knows, about fibroids. Because to be honest, there were, in that 4 doctors before I found my one, there were some that said things that I looked online, and the first thing I found, used the Mayo Clinic as a resource most of the time, was not true. So that's my reset. So one of the things I want to talk about, one of the experiences I had when we talk about screening, is that the first doctor that I saw, the one that told me, you're not having kids, she did my pelvic exam, and she was like, okay, I can schedule you for surgery in 2 weeks. Whoa, what just happened? Isn't there, and again, I'm new to this, so I'm thinking, given where we are technologically, shouldn't there be some sort of diagnostic test besides you just, excuse my language, just sticking your fingers on me? So you can get a better picture. So I actually left the doctor because I was so frustrated with just the whole interaction. But after, again, looking things up, and so make sure that you kind of understand what your options are in terms of, the most accessible is an ultrasound. I'm sure, as the doctors will tell you, there's other things that you might want to get in terms of if you're going into surgery. And that's the thing, she was taking me to surgery and not suggesting anything further. Oh, I'm sorry, I have to add this. And then I said, well, I would like to preserve my uterus, because she was prescribing a hysterectomy. And she said, well, we'll see when we get into surgery. So yeah, so you know why I left that doctor's office. So the other thing to do is when you get an ultrasound, I called it stats because there is a number in there, right? So size, number, location, because that's actually going to affect what treatments are available to you. So I'm sure the doctors will talk about what that means, and there are so many options now based on these things, that if one of the other things that we talk about the White Dress Project is if someone tells you there's only one option, walk out. Because there are various options that can be used in combination. There's so many options now for uterine fibroids. A lot of research has gone towards it. So know your stats, and that will give you some idea. You could do more research, but you have to know them yourself. And then this is this whole concept of comfort and consistency. right? The ideal is that you'd stay with one doctor, one hospital system, but if you're not comfortable, it is really important. So we were talking about mind, body, and soul. If you're not comfortable, your outcomes will be affected. So if you're not happy with your doctor, if you're feeling like, I guess I want to, all of that affects your stress level, the way in which you're going to approach it, your mindset. So it is really important that you balance those two things. All right, so now that we've talked about that, we've got kind of into the mind, body, soul, I did want to talk about, this is actually a graphic from one of the researchers that presented at our last What the F. Our research committee has a monthly series, and I'll actually tell you what this month's series is about, called What the F, fibroid, for fibroid, research forum. and one of the things we talked about were the key risk factors. And I'm not going to go into all of the stuff that leads to the fibroid, but this is kind of, common sense, if you will, because we're exposed to so much, and it leads to chronic inflammation, right? And that includes stress, and I'll talk a little bit about racism and Black women in particular, vitamin D deficiency, exposure to EDCs, which is something we're actually going to cover in this month's. EDCs are endocrine disrupting chemicals. So, you think about all the personal care products, your lotions, your makeup, etc. Your plastic water bottles. I'm not going to go down that path. So, one of the key and most actionable risk factors for fibroids, and so this is for if you have, so how many people have had a fibroid, had diagnosis in the past? Okay. And how many people have had some sort of procedure, surgical, for their fibroids? Okay, so most of the people. All right. And how many of you remember doing a vitamin D test? Okay, so sort of half of those people. So it is pretty, and the doctors can also talk to this, the doctors that we've spoken with have said that it's pretty common, very common, that someone with fibroids has a vitamin D deficiency. And so again, vitamin D deficiency, if you look at your numbers for that 25-hydroxy vitamin D, you'll see it on your lab test, of 30 to 80 should be the number, is normal, within range, I should say. I don't like to use the word normal, because everybody's normal is different. So his prescription, particularly if you have fibroids, and he's got the research to back up that you can affect the size of your fibroids using vitamin D, and his prescription is 5,000 IUs per day, and EGCG, which is a green tea extract, at 800 milligrams per day. And what he's seen is that this can really have an effect early on. So if we draw the line, right, and connect the dots, if you have a change in your menstrual cycle, but you have no other symptoms, if you can find out that you have a pea-sized fibroid, getting on and making sure that your vitamin D is at the right level, so get tested first. And if you're in the range, just kind of stay on top of it. And then if you're not, bring it up. And we have the entire presentation that Dr. Al-Hindi did with us is actually on the White Dress Project YouTube channel. It's the May What the F, called How Can I Prevent Fibroids? And we go into the details, so I encourage you to do that if you're thinking about this. And I apologize for the lightness of this. So the other risk factor I want to talk about, especially given the theme of this event as mind, body, soul, is stress and distress. And I could do a whole segment on this. But the key is that when you have that chronic inflammation and stress, and it leads to chronic mental and physical disease conditions. And it also affects your mindset. When you're sick, what do you feel about the things that you need to do? You're less energetic about them. You're not able to do all that you can do when you're feeling sick. So your mindset changes. And that actually reduces your immunity and increases your susceptibility to further that chronic disease condition. And so then your risk of, and we saw it here is, with the previous graphic, is that for fibroids in particular. So fibroids have a pretty high recurrence rate, for those of you who don't know. So this is why, even if you're not preventing it as primary prevention, which means before it even occurs, secondary prevention is preventing the recurrence of it. So current research has found a positive association between major life events. So for those of you who don't know, stress is stress. Stress is unavoidable. And stress is not distress, right? Stress, I have a little stress coming up here because I'm sick. I'm going to present. It's good to have a little stress, right? It helps you perform. But when you chronically have it, when you're chronically stressed and you don't recover, kind of bring those levels of that cortisol, et cetera, down, then you start to affect your health. And so they have found an association between major life events. That could be you getting married, which is a great thing, but for those of you who have had big weddings, there's a lot of stress involved in that. So hopefully the honeymoon is a recovery period, but the idea is that you can't avoid it, so you have to make sure that you recover before you get into distress. Childhood abuse. So that's obviously a negative, distressing scenario. And then generally, so these are all the names of studies that have been done that have proved the association between the stress and uterine fibroids. Now, to talk specifically about Black women, fibroids and stress, there were two articles that were written. This was, Essence was 2021, and Capital B, Atlanta, was just this past year. And has anyone heard of the term weathering? No. Weathering is well, there's a general term, weathering, of course, which means the erosion of something over time, right? It gets weathered. Within the public health arena, weathering is this concept that the exposure that we have to micro stressors, so specifically in the context of sort of racial disparities in health, that it's caused by this consistent exposure to daily micro stressors that you experience and how that contributes to chronic stress, inflammation, and all of the disease conditions that result. So it is absolutely critical for Black women to find ways to recover from stress and not enter into distress, to find ways to reduce that inflammation ultimately through stress recovery. So there's a lot of knowledge around prevention and fibroids and breaking the cycle. There's a bunch of information about obesity, vitamin D. I mentioned endocrine disrupting chemicals. Your gut, everybody hears about probiotics. They're always talking about them on television. They more talk about it because you can go to the bathroom, but there's a whole lot more involved in there. Other environmental risk factors. And then just generally when you talk about, again, this sort of racial, cultural impact. But there's still a long road. So I'm going to give you some ways that you can help. As a health and wellness coach, my focus is on action and what you can do with this, hopefully this energy that you have around, okay, so what can I do to help break the cycle? So you can join our resource list. So you can send an email to research@thewhitedressproject.org. And we are creating this year a new pipeline to research projects that are going on that are specifically around uterine fibroids, so that we can find out more about them, so that we can figure out more about how we can break the cycle. So we need more people to participate, particularly Black women, in research projects. And we had this conversation at our last conference. There's a lot of history with Black people in research, particularly medical research. So acknowledging that, what we want to create with the White Dress Project is an environment that is very transparent in terms of the research, what's being done, how it's being used. I mean, there's of course all kinds of things that are in place now that are intended to prevent some of the historical challenges that we've had. But we want to do a little bit more. We want to take it up to the next level, realizing that that's a concern, but also realizing the benefit of research and us getting involved in the research. So the second, this is my little commercial. Spread the word about what the F. So I'm gonna get to the one that we're gonna be doing this month, but it is a great way to stay informed. And this is for, we use the phrase each one teach one, because the more you know and the more you support one another in community and have these types of conversations about what's going on, whatever you call it down there, the better our outcomes will be. The more silent we are, the worse we are off. Us not talking about it does not help it at all. Right? So the shame and the guilt and all of that stuff, we have got to let go of. In fact, I usually I was going to ask the gentleman that were up here playing, but now, you should, for the women in your life, our men should be asking, what's your cycle this month? So we're the people that create the world, right? Without that cycle, none of these people are in this room. That's right. So it really amazes me. I actually was talking to my brother. My brother's like, can we not talk about this? And you have to know me to know. I was like, my hot flash didn't get that memo that we should talk about it. So it is really, really, really important that we get educated, that we spread the word, that we actually bring in. So it's not just about women. This is all up to us. You know, I mentioned that our founder is having some fertility challenges, largely as a result of her fibroids. Her husband is there for her. Our last conference, I swear, the support from the men, I think, was the reason why the women that their significant others were not in distress, because they provided recovery. They were the shoulder that they could lean on, that they could cry on, that they could recover with. So it is extremely important that everyone gets educated, and it starts once we get into these forums, into these discussions, into these events. So the last thing I'm going to mention about how you can help is to demand your local politicians, and we're going to have a campaign this year around that. There is an act called Stephanie Tubbs Jones Uterine Fibroid Research and Education Act. Anybody heard of it? Okay. It is designed to set up funds, to allocate funds for research around uterine fibroids. Stephanie Tubbs Jones was the congressperson that brought this up for the first time in 2001. It has been brought up not every year, but a number of times since then. It has never passed. So we're at the 20-plus year. She has since passed away. And in the meantime, the NIH, National Institutes of Health, which funds a lot of the medical research, right, for, I academic institutions, etc., has dedicated, and we had the numbers, I think it was last year, it was 16 million. And smoking research was close to 1 billion. I don't know what we're learning new about smoking, but I hope that money got put to good use. So just as a basis for comparison, right? And then when you look at the people, I mean, again, I have a bias. I think women can, if we're doing well, everybody's doing well. So this is an area of focus that we need to dedicate dollars to, and this is what the Stephanie Tubbs-Jones Act is about. So we're going to have a campaign. It'll probably kick off in October because that's when the sessions will start. But we will look for people to get engaged. We'll probably have a letter you can send, an email. You can of course call so that we can make this happen. So again, please email us with the subject, I want to help break the cycle, and we'll put you on the list of not only research participation opportunities, but also you'll also be informed of the monthly research forums. Okay, so let's do something. All right, so I'm going to ask a question. So how many days can you go without eating and still survive? Okay, I heard a lot of 3 days. 3 days? Yes. What did you say? Oh, you said 5. I thought you were raising your hand. She was like, no, that's fine. Okay. So, I'm going to tell you, you will not die in 3 days. You won't. So, and of course, again, everybody's different, right? But there's a number out there that's around, I don't know, it's more than 2 weeks. Right? If you have water, your body will keep functioning. You'll start eating away at, your fat and your muscle, but you'll be alive. How long can you go, now that I said you have water, how long can you go without water? He's like, let's go with this 3 days. 3 days, again. So yeah, it's about 3 days. How long can you go without air? Okay. All right, so I'm going to propose you, yes, you're right. I'm trying to, what did my doctor say? How long can you go without air? Very limited, very limited. You wouldn't make it through my presentation, let's say that. So, I am going to posit to you that breathing is one of the best things that you can do to recover from stress. And so when I say breathing, what do I mean, right? Because we're like, well, we haven't passed out yet from your presentation. So, you are breathing now, but we are talking about intentional breathing. And, okay, pop quiz. Inhale or exhale triggers the relaxation response. Gold stars for everybody. You must have done that last year. So yes, your exhale. So, within yoga and some other, modalities, the exhale is your focus point, and you want to draw that exhale out as long as possible. Okay, so that's your intentional breathing. And you can really kind of measure how you're improving, and the research that has been done for this type of breathing called cyclic sighing. It's research done by someone named Andrew Huberman, Dr. Andrew Huberman out of Stanford, and he's shown that you can reduce anxiety, you can improve sleep, and that was from 5 minutes a day was the protocol that he used. So it doesn't take a lot of time. Now, what is cyclic sighing? You're going to breathe in through your nose, and then when you fill your lungs, you're going to take this second sip to really expand as much as possible. And then, very slowly, you're going to exhale through your mouth until you feel that you have fully removed all the air. So, we are going to do that for the next 5 minutes. So, I want you to get comfortable, not too comfortable. Ideally, if you're going to do this sitting in a chair, which you all are, please nobody lay on the floor. I don't know what's been going on there. Put your feet grounded on the floor. So sit up in the chair. So don't cross your legs or cross your ankles. You can put your hands wherever they're comfortable. You can close your eyes if you want. And there is a video which I guess I can make sure that the first lady gets, or Lisa, you can make sure that, so that this is a video you can do, it's on YouTube, which is kind of a guided, and sometimes I have to slow it down, but is it gonna play? Don't do this while driving. That's the exhale. On that exhale, focus on relaxing your body. So can somebody share their experience? Okay. Did somebody fall asleep? Did it feel like it was long? Like you were like, oh, isn't it 5 minutes away? Yes? So some people, you felt lightheaded? So, and that may happen, and likely that's because you've been breathing differently, right? So you're getting a lot of different air, you're letting go, a lot of different, so you may feel kind of, maybe it feels lightheaded, etc. So remember, so for me, the first time I did it, I was like, isn't this 5 minutes up? So as you do it, and you really allow yourself, because this is partly, it's a mind, body, soul thing, right? You really need to allow yourself, because you may have a bunch of things pulling at your attention, distractions, etc. You really have to allow yourself to be in that 5-minute moment. It is only 5 minutes. The things that we do for our health, to run, like, I just gotta get this run in 20 minutes. I just gotta, I gotta go to my line dance class for half an hour. Whatever it is you do, you can do an extra 5 minutes of breathing. Because this is for your physical, your mental, and your emotional health. And that can affect, those are all interconnected. So again, we'll get that to you. So I mentioned the What the F virtual series, so it's online, so everybody can make it. They're usually the third Thursdays, it varies, 8 o'clock Eastern. Okay, Arizona always messes me up. What are you guys on? It's 5 o'clock, okay. Is it, I don't know, I'm always like, because you guys don't change, right? I wish, that's a good thing. So whatever they said. And our special guest presenters are going to be from, I mentioned the Al Hendy Lab that does the research around prevention lifestyle. We co-authored a paper with them around lifestyle and fibroids, so we'll be talking about some of the conclusions from that. And the paper was really a literature review of the existing research that's been done around various methods of prevention for fibroids. And then there is a study being done at NYU, the Center for Fibroid Care, the doctor in charge of that research is going to come and present preliminary research. So their research is not done yet. They're in the middle of the project, but they've had some insights that they're going to share with us. So it should be a really interesting session. So again, our goal is to get research out there and help to recruit for research. So there is a study that's going on, and this is going to be one of those things where there's nothing in the local area, but if you have friends, which I know you do outside of this area, they're doing a fibroid and infertility trial. So they'll be doing some fertility treatments as well as they're actually using the EGCG as a part of this to see how it affects fertility and fibroids. All right, and with that, that's my address. So I'm telling you, I guess I should change that color, at thewhitedressproject.org. And you can also follow us on social media as We Can Wear White. I am on social media usually as Embody Well, and if you will be going, I think, to Q&A later on, but I can take questions now. I don't know if we have time.
We'll do it at the end.
Okay, we'll do it at the end. I'm following you guys. Thank you all.
It is our esteemed pleasure. Thank you guys for coming. It is our esteemed pleasure to present Dr. Michelle Louis and Dr. Jordan Michelle Duncan. Dr. Louis is a fellowship-trained minimally invasive gynecologic surgeon. She's an associate professor of medicine at Mayo Clinic. And Dr. Jordan Michelle Duncan, she's a minimally invasive gynecologic surgery fellow at Mayo Clinic. Let's give them a warm welcome, please.
Good morning, everybody. Oh, my clicker. Okay. Thank you. Like she said, I'm Jordan Michelle Duncan. I'm one of the second-year minimally invasive gynecology fellows at Mayo Clinic. Thank you for having us today. We will be talking today about uterine fibroids. I'll be talking about epidemiology, the symptoms, and diagnosis. So first, we're going to start off with the basics of female anatomy. So the vagina is the entryway to the cervix. The cervix is the entryway to the uterus. And this is what gets 10 centimeters dilated when you have a baby. The uterus is where the pregnancy develops. The uterus is composed of the outer layer, which is called the serosa, and then the wall of the uterus, which is called the myometrium, and the lining of the uterus called the endometrium. So next are the ovaries. We do have 2 of them, and this is where the egg is stored and developed, and this is also where your female hormones come from. The fallopian tube carries the pregnancy from the ovary to the uterus, and that's where in the uterus, the baby grows there. So what are uterine fibroids? They are non-cancerous, smooth muscle that is hormonally responsive. As you can see in this picture on the right, the fibroid is growing in the wall of the uterus. So how do we name fibroids? Where are they located? So fibroids, as you can see on the right-hand side, one is in the lining of the uterus, which is called submucosal. So sub is below, mucosa is the lining of an organ, so it's in the lining of the uterus. On the left-hand side, just adjacent to that, you can see an intramural fibroid, which is a fibroid that grows in the wall of the uterus. So intra meaning within, mural meaning wall. Subserosal, right below that, is growing on that outside lining of the uterus. So who can fibroids affect? We don't really know the true rate of new cases and old cases because a lot of fibroids are asymptomatic and 25% of fibroids need to be treated. So 75% of them don't need treatment. However, we do know that it affects women of reproductive age, and the rate of fibroids increases up until menopause. So some risk factors for fibroids, which Tanya already talked about a little bit, but high blood pressure, high weight or body mass index, dietary changes such as increased levels of eating beef, red meat, alcohol consumption are all risk factors for fibroids. As well, we now know that Black women are 2 to 3 more times likely to have fibroids, and their fibroids are more likely to be clinically significant. So they're more likely to have larger uterus, larger fibroids, have complications from fibroids such as anemia. And why we think this is probably multifactorial, but lifestyle changes, diet, as well as social stress, and perceived racism is another reason why Black women are 2 to 3 times more likely to have fibroids. All right, so now what are some symptoms of fibroids? So 50% of fibroids patients don't have any symptoms of a fibroid. However, if you were to have symptoms of a fibroid, these would be them. So like Tanya talked about, heavy or prolonged menstrual bleeding, and then something that we call bulk symptoms, which are symptoms of a fibroid pressing on different organs. So you may feel pelvic pressure, pain, you can also feel abdominal bloating, kind of looking like you're pregnant, urinary issues such as having to go to the bathroom a lot, not being able to empty your bladder all the way, or things like constipation. These symptoms not only cover fibroids, but there are some other abnormalities that have overlapping symptoms, such as endometriosis, which is when endometrial-like tissue grows outside of the uterus in the abdominal cavity, normally in the pelvis. That can cause painful periods, it can cause pain with sex, and painful bowel movements. Another abnormality that can have some overlapping symptoms is adenomyosis, which is a cousin of endometriosis, where the lining goes into the wall of the uterus, and that can cause heavy and painful periods. But also things like uterine polyps can cause heavy, prolonged bleeding, even bleeding in between periods, and that is just an outgrowth of the lining. So if you have any of these other symptoms, along with these symptoms, I would definitely talk to your doctor about that, because there could be not only fibroids going on, but other things in addition to fibroids. So how do we diagnose fibroids? Unfortunately, we start off with a pelvic exam, which no one thinks is very comfortable. But it actually does give us a good amount of information. So first, the pelvic exam has two components of it. It has a speculum exam and what we call a bimanual exam. A speculum exam is a dreaded instrument that we unfortunately use to look at the cervix and look at the vagina. That tells us, one, how much you're bleeding. We're actually able to quantify that. And two, if there's another reason that you may have this bleeding as far as abnormalities of the cervix, abnormalities of the vagina. So then we normally do what we call a bimanual exam, which is an exam where we insert 2 fingers into the vagina, and that gives us a wealth of information as far as any abnormalities with the cervix, the vagina, but we can also feel the shape of the uterus, whether it has what we call irregular contour, which is little bumps, which may mean that it has fibroids on it. But we also can tell if the uterus is stuck to any of the other surfaces in your body, and that gives us more information as far as how do we treat fibroids and what is the best route to give you the best satisfaction and the best recovery from your symptoms. So next, we normally do laboratory testing. The first thing, the easiest thing, is a pregnancy test, because that is a different pathway if you're pregnant, and normally pregnancy can actually have irregular bleeding, so that may be a reason for your bleeding. Secondly, we like to know about whether your hemoglobin or your blood count is low. This one tells us how much you're bleeding, and also gives us a good amount of information if we need to treat your anemia or your low hemoglobin. And some things that we may do for that would be iron, whether it be a pill or it may be an infusion, or sometimes we need to give you blood. But you would talk to your doctor about this, and especially if you have symptoms of anemia, such as fatigue, lightheadedness, shortness of breath, you need to let them know so that they can do this test as well. And then the last thing is an endometrial biopsy. This gives us information about precancer or cancer. And women who are over 45 who have abnormal bleeding are at higher risk for cancer. And so this test, we need to rule that out. And also, if you're younger than 45 and you have risk factors, this is something that your doctor may recommend. So I would definitely talk to your doctor about, your risk factors, and have, a collaborative thought about risk factors for endometrial cancer. So now, how do we diagnose fibroids as far as imaging? So there are a couple imaging modalities that we can use to diagnose fibroids. First, a pelvic ultrasound, hysteroscopy, saline infusion sonography, magnetic resonance imaging, and I'll talk about each of these in detail. So a pelvic ultrasound uses sound waves to create an image, and pelvic ultrasound is a combination of an ultrasound over top of the abdomen, which you can see at the top, and then the second component is a vaginal probe that we use to get an internal look at the organs. The pelvic ultrasound, when you see fibroids on it, looks like rounded masses. So pros and cons to a pelvic ultrasound. It is widely available, it has low cost, and it has a high rate of finding small fibroids. However, if your doctor has determined that, oh, you have an enlarged uterus or you have many large fibroids, then an ultrasound may not be as helpful because it can impact visualization. And pelvic ultrasound, because of those two components, it does require tolerance of a vaginal exam. So if you have a really tough time with the speculum exam or that pelvic exam, or had a previous, concern about having an ultrasound and pain from an ultrasound, I would definitely bring this up with your doctor because we can either give medication to, relieve anxiety for this test, or we can forego this test and do another test that may not require the vaginal component. So saline infusion sonography is an ultrasound, but we use fluid and we place that inside the uterus to get a good look at the cavity of the uterus. So pros and cons to this is that it assists us in planning for removal. We can also use it for fertility evaluation if that is something that you are considering. It is an office procedure, and it does have a higher rate of finding those fibroids that are in the lining, called a submucosal fibroid, more than an ultrasound, and it's a low risk for infection. The downsides to saline infusion sonography is that it's diagnostic only. So it only tells us where the fibroids are. It doesn't tell us, or it doesn't treat the fibroids. And it only evaluates fibroids that are within the cavity. And it does require tolerance of vaginal exams. So now hysteroscopy is where we insert a camera into the uterus and look at the lining of the uterus, as you can see here. So hysteroscopy, we insert the camera through the vagina into the cervix, and then we add fluid, like that last study, to be able to see the cavity well. This procedure can be done in the office, or it can be done in the operating room, depending on your desire for comfort. And it is diagnostic, so it can tell us where the fibroid is in the cavity, but it also can treat the fibroid once we are able to find it. We are able to use instruments with that camera in order to remove, say, a fibroid at that time. It is low risk, and the downsides are that it only evaluates fibroids in the uterine cavity. So those fibroids that are intramural, so within the wall of the uterus, or on the outside of the uterus, we cannot see with a hysteroscopy. So now an MRI uses magnetic fields to generate images of the body. It doesn't use X-ray or radiation, and it gives us kind of a bird's eye view of the uterine structures, the ovaries, the fallopian tubes, and the cervix. So the pros to an MRI, it is able to determine size and location of fibroids, and it can distinguish fibroids from other pathologies. So for example, if you have symptoms of adenomyosis, that cousin of endometriosis, we may be able to see this on an MRI. Or if you have ovarian cysts, we can also see that. And it has a high rate of finding fibroids, more so than an ultrasound. It can assist in planning for removal if that is something that you discuss with your doctor. They may want to get before your surgery. And the downsides is that it is a costly test. And it does require you to kind of lay down in a small space, and it has a lot of noise. So if this is something that you may be like claustrophobic, you definitely want to tell your doctor, because they can give you, medication before the test, or they may decide that maybe we don't need to do this exact test. All right. So now I'll bring up Dr. Louie, and she's going to talk to you about treatment modalities.
Might not be the best treatment for somebody else. So it's not one size fits all. And in order to figure out what the best treatment is, we need to know, do you care about preserving your uterus? Is it part of your identity? Forget about having children. Is it important to you to have that uterus? Or are you planning for fertility? Are we trying to put a baby in that uterus? Because that really changes the kind of treatments that are the best. Maybe the most important thing to you is just to get your symptoms taken care of. You just need to go to work, you need to take care of your kids, you can't have your period getting in your way. How much does your period bother you? Do you want it completely gone? You never want to see a single drop of blood again? Or you just want, a nicer period? You want a sort of more regular flow? I feel like this is really Maybe the most important thing to you is that you don't ever have another fibroid in the future. Maybe you're worried about something happening in the future like cancer. Or as Dr. Duncan said, maybe you have other things going on. Maybe there's adenomyosis, maybe there's cysts, maybe there's something else that needs to be taken care of at the same time. Wouldn't it be nice if the procedure for your fibroids also helped you with your other problem? And then if we are talking about surgery, what are your thoughts about recovery? What are your thoughts about the risks of surgery? Because every procedure has a different level of risk. So we're going to go through all these different treatment options, and we're going to talk from the most aggressive options and to the least aggressive options. And we're going to start with medications as the least invasive way to treat your symptoms. Now, this doesn't always treat fibroids. Sometimes we're just helping to get your period lighter. Sometimes we're just helping with your pain. But that's important because that's your quality of life. So if medications can help you get to work and do the things that you want to do, that might be the best choice. So the benefits of medications, generally, they're really low risk. Every medication has side effects, but generally these medications don't carry with them the same risks as surgery does. They're easy to do, pills, patch, vaginal ring, many different medical options, and if you don't like them, you can stop them. They're reversible. So you haven't done anything permanent. You can't necessarily turn back time and undo the surgery if you decided that wasn't what you wanted to do, but you can stop your medications. You haven't done anything that's irreversible. And most medications are less expensive than surgery. The cons is that every medication has side effects. Generally, most of the medications are well tolerated, but again, not every person is going to respond the same way. So we got to find the shoe that fits the right foot. Of course, the biggest downside of medications is that they're temporary. They will only work when you're taking them. And so some people feel like it's a Band-Aid. Maybe this is not the best long-term option for me if I'm 30 years old and I got 25 more years of periods. And if you're actively trying to get pregnant, most of these medications will not allow you to get pregnant or conceive. So if you're actively trying to get pregnant, going back to your goals of care, medications is not going to be on the list of things that we talk about. So who would be a good fit for medications? If you have symptoms, but they're pretty mild, they don't prevent you from going to work or school, medications might be enough. If you're really worried about surgery, or your doctor is really worried about surgery, maybe medications is a better fit. And oftentimes, I use medications as a bridge. It's temporary, but if you need to do something really important next week, I can't do surgery that quickly maybe the medications is a good bridge to that important event. Sometimes I have patients tell me, I'm getting married next month, I'm wearing white. I need something that's going to help, but I don't want a big surgery because I want to look great, I want to be ready, I want to be in the right state of mind. Maybe it's just okay, a Band-Aid is okay. Maybe it's just a bridge for a little while, and then it's a long-term fix. Medications are not right for everybody. There are some people who will have medical problems for which medications are too high risk. Maybe it will intermix with some of your other medications, and so this isn't the right fit. If you have really severe symptoms, really large fibroids, medications may not be enough. If you're actively trying to get pregnant, we talked about medications, not a good option. And if you've gone through menopause already, medications aren't a good fit. Okay, so surgical treatments. The first one is endometrial ablation. I put it first because it's not really treatment for fibroids. It's really treatment for bleeding. It's a minor procedure in which a small device is placed through the vagina into the uterus, and we destroy the lining of the uterus so that your periods stop. It doesn't treat the fibroids itself, but for some people for whom bleeding is the most severe symptom, this is a good treatment option. So the pros of this is that it's very low risk. It's a completely vaginal procedure, no incisions, recovery time is 1 to 2 days. It preserves the uterus. The downside is that it doesn't treat your fibroids. So if treating your fibroids is really important, it's not just the bleeding that's causing you problems. This is not a good choice. There are some people that can develop scarring inside the uterus after this procedure. It's a low percentage, 10 to 15%, but it's more common if you've had your tubes tied that you can have problems after this procedure. It's called post-ablation syndrome, and it can cause a lot of pain. So if you're concerned about this complication, this would not be the right choice. And you must always use birth control after this procedure because this procedure destroys the lining of the uterus, which Dr. Duncan just taught us, is where your pregnancy grows. So you cannot get pregnant after this surgery, but because you still have a uterus, technically that baby could start, and that would be a really bad complication afterwards. So we want to make sure that people have a very reliable form of birth control if they choose this. So this procedure is really great for people who want to keep their uterus but do not want to get pregnant. They want a low-risk surgery and the predominant symptom is bleeding. You may have fibroids, but they're on the surface or outside part of your uterus, and so they're not interfering with this procedure. Maybe you just need something that's really fast, 1 to 2 day recovery, back on your feet, and you're really close to menopause. You just kind of want to get a bridge of your symptoms until then. And of course, having a partner, having really reliable birth control is important. It's not a good procedure for people with really large fibroids. If you have other symptoms, like Dr. Duncan talked about, urinary symptoms, bladder symptoms, bowel symptoms, this is not a good choice. If you're very young, it's most likely not going to give you enough relief for long enough. This procedure is really good for the first 5 years, but after about 5 years, periods start coming back. So if you're very young and you're not close to menopause, you probably will start to have symptoms again. If you want to get pregnant or you're not interested in preventing pregnancy, if you are high risk for cancer or you've had your tubes tied, we discussed that this procedure might cause some complications. The next procedure is called a transcervical radiofrequency fibroid ablation. It's a mouthful, so the company has named their device Sonata, and that's the billboard in the back and the bags on your tables. Sonata is a procedure where we place a small ultrasound through the vagina into the uterus, like you can see in the picture. We then place an array into the fibroid and heat the fibroid up really hot so the tissue is destroyed. And that causes the fibroid to shrink and your body absorbs that tissue. So this is really nice because in the trials, over 90% of people felt like their symptoms got better. And there are no incisions, 1 to 2 day recovery, very low risk, outpatient procedure. The downside is that it preserves the uterus, but we don't know if it's okay to get pregnant afterwards. We know that the people who have gotten pregnant afterwards did well, but there just aren't a lot of them because it's a fairly new procedure. So if you're actively trying to get pregnant, this is not the right procedure for you. And then sometimes we can't access all of the fibroids. Like Dr. Duncan said, like Tanya said, the right procedure for you depends on the size, number, and location of fibroids. So not every fibroid can be accessed with this procedure. It's really great for people who are interested in preserving the uterus but not actively trying to get pregnant, people who want a low-risk surgery and have mostly period-related symptoms, and small to medium fibroids. If your fibroid is above 7 centimeters, it's considered pretty big, and it's probably too big to be treated with this surgery. If you have fibroids in the cavity of the uterus, we'll talk about a different procedure for that. If you're actively trying to get pregnant, and again, a high risk for cancer, we wouldn't recommend this procedure. Moving on to laparoscopic radiofrequency fibroid ablation. So same technology, but instead of going through the vagina, the natural opening to the uterus, we're going through the abdomen. There are 2 small incisions, so it's considered a minimally invasive procedure. Again, more than 90% of the people when they studied this reported that their symptoms got better. So it's pretty good at alleviating those symptoms. It's a very low risk procedure, and it has a short recovery time of 5 to 7 days. The downside is that, again, is it new enough that we just don't know if it's okay to get pregnant afterwards. They have studied the people that did get pregnant, and those people had very good outcomes. There were no downsides, but there just aren't enough of those people yet for all the doctors to say, yes, this is okay to get pregnant afterwards. And again, we can't always access all the fibroids with this technique. So it's really good for people, again, interested in having children, interested in preserving the uterus, but not necessarily interested in having children. If you want a low-risk surgery and you mostly have period-related issues, and again, small to medium fibroids. Larger fibroids may not be able to be treated completely with this technique. If you have fibroids within the cavity of the uterus, not great for this one. And if you're actively trying to get pregnant or a high risk for cancer. So you can see that it's very similar to the last procedure. It's just a different route of surgery. And the difference between them really depends, again, on where your fibroids are located and how many fibroids you have. Uterine fibroid embolization is another procedure. This one is done by radiology. They make a small incision in the groin or the neck, and they place a catheter or tube into the blood vessels that feed the fibroid. They block the blood vessels to the fibroid, and that causes the fibroid to shrink. The fibroid never goes away, but it gets a lot smaller, and 70 to 90% of people experience an improvement in their symptoms. Not everybody though, and about 20 to 30% end up wanting something else afterwards. And in one study, hysterectomy was the thing that they chose. So about a third of people who have this procedure feel like their symptoms weren't adequately treated and had a second procedure. But it's really low risk. One small incision, very minor anesthesia, outpatient procedure. People mostly take about 7 days off of work, so it's a pretty short recovery. The downside is that we do not recommend getting pregnant afterwards, so this is not a good procedure if you're actively trying to conceive. And some people have ongoing pain as those fibroids are shrinking for about 3 to 6 months. So you may need to take an over-the-counter pain medication for 3 to 6 months while those fibroids are getting smaller. This is great, again, for people who want to preserve the uterus, not actively trying to get pregnant. If you really want a low-risk procedure, you're really worried about anesthesia, this is a really good option. And you're mostly concerned about period-related symptoms, heavy or prolonged periods. I really like this option for people who have a lot of fibroids, more than 10, more than 15, more than 20, because this procedure can address all of them. People who should not get this procedure, we talked about people actively trying to get pregnant. If you have fibroids on the very surface of your uterus or the very inside of your uterus, they can cause complications afterwards. So I don't recommend it for those people or those types of fibroids. And if you mostly have bulk symptoms, so urinary frequency, if you have constipation because the fibroids are so big, they're pressing on the organs around them, this procedure might not shrink them enough to alleviate them satisfactorily. And again, if you're a high risk for cancer, we don't recommend preserving the uterus, so this wouldn't be a good choice. MRI-guided focused ultrasound is one that people come to talk to us a lot about at Mayo Clinic because it's a really unique procedure that's done by radiology. There are very few sites in the US that do it, and Mayo Clinic in Rochester is one of them. It performs similarly to the embolization in that about a third of people end up wanting to get another procedure afterwards, so they're not fully addressed. But it works in about 70% of patients, and it involves going to an MRI machine, laying down for a very, very long time, and having a laser focused into the uterus to shrink the fibroids. So it's incisionless. It helps to decrease their size with no incisions at all. So it's really low risk, really short recovery. The downside, again, it's not well studied for future pregnancy. It cannot be used for all fibroids. And unfortunately, it's not covered by most insurances. It's only offered at very select places in the US. Again, Rochester, Minnesota, the Mayo Clinic there is one of those places. And you have to really be able to lie flat for a very, very long time while they're treating the fibroids. There's a very specific list of fibroids that can be treated with this kind of procedure. They have to be small enough, in the right location, and so it has to be sort of the Goldilocks of fibroids. This is not one that most people do. The people who do it are those that are interested in preserving their uterus, They don't want any incisions, and they meet that fibroid selection criteria. The people who are not good candidates, if you have those large fibroids, if you have a lot of them, if they're positioned more towards your back instead of your front, that MRI-guided focused ultrasound isn't going to be able to reach those fibroids if you're actively trying to get pregnant or high risk for cancer. Myomectomy. This is one of the most common fibroid procedures we do because every single thing that I've talked about to this point, what is the downside? We don't know about pregnancy, or you shouldn't get pregnant afterwards. So this is the gold standard for people who are actively trying to get pregnant or who want to keep that window open. The route of this surgery, where we remove the fibroids from the uterus, depends on the size, number, and location of fibroids. So obviously we always want to do the least invasive option, and that's vaginal. We don't make any incisions, we just go through the natural opening in the uterus and we remove the fibroids. But you have to have submucosal fibroids, or fibroids within the cavity of the uterus, to be a good candidate for that route of surgery. Laparoscopic or robotic requires 4 small incisions in the uterus, in the skin, and then 1 incision in the uterus to remove the fibroid. And the recovery time is about 2 to 3 weeks. And then sometimes for people who have a lot of fibroids or really, really big ones, then we make 1 single incision, just like a C-section. And recovery for that is obviously going to be longer. It's about 4 to 6 weeks. So the pro of the myomectomy is that it's the gold standard for fertility optimization and preservation. If getting pregnant is your #1 priority, this is certainly the best choice. It's also highly effective for both your period-related symptoms and for those bulk symptoms, because we're actually removing the fibroid from the body. So it's no longer pressing on your bladder or on your bowels. The downside is that the route will depend on the size and location and number of the fibroids that you have. So sometimes the recovery may be long if you have a lot of fibroids or they're very large. Most physicians will recommend that you wait a minimum of 3 to 6 months before getting pregnant after the fibroids have been removed from the uterus, and that just allows the uterus to heal. And you may need to deliver by C-section. So once we make an incision in the uterus, that's a weak point, and your pregnancy physician may not recommend delivering naturally through vaginally if you've had that incision in the uterus. So who should get the myomectomy? We all know, right? If you're actively trying to get pregnant, you want to preserve the uterus, this is a great procedure. If you really have a lot of bulky symptoms, because the fibroids are pressing on the bladder, pressing on the intestines, this is a good way to get them out. And if you have a submucosal fibroid, so that fibroid within the cavity or center part of the uterus, getting a vaginal myomectomy is the best way to treat that. If you have really mild symptoms, you may not want to do this procedure. If you're really high risk under anesthesia, this might not be safe for you. And again, if you have a high risk for uterine cancer, we have to think about some other options. All right, last on the list is the hysterectomy. This is where we remove the uterus. As you can see, the picture on the right, on the left, the uterus is the center of that diagram. We don't remove the ovaries when we do a hysterectomy. You have the option of removing fallopian tubes and cervix, and there are pros and cons to each of those decisions. Generally, almost always, if we do a hysterectomy, it's with small incisions, so laparoscopic or robotic. We very, very rarely would ever need to make a large incision to do a hysterectomy. So a hysterectomy gets a bad rap, right? But there are some pros to it. If you never want to see any bleeding ever again, if you get rid of the uterus, not a problem. If you never want any fibroids ever in the future, that's the way to get rid of them. And if you're worried about cancer. So we've talked about that throughout this morning. If you're worried about cancer in the uterus, cancer in the cervix, we can reduce the risk by removing the uterus. We talked about the option of keeping or removing the fallopian tubes and cervix, and some of the pros of removing the fallopian tubes is that it decreases the risk of ovarian cancer, because most ovarian cancers actually come from the end of the fallopian tubes. If you get rid of the cervix, you can't have cervical cancer, no more pap smears, no more speculums. So some people choose the hysterectomy because they have fibroids and they have other problems that they just don't want to deal with anymore. Some people choose it just because they don't want to deal with it again. This is their third fibroid surgery. They want it to be their last. That's okay. That's what this decision process is all about, finding the right procedure for you. Obviously the downsides, if you want your uterus, this isn't the right surgery for you. It does have a 4-week recovery time, so I tell patients it's an investment. You'll never have another period again, but you gotta take it easy for 4 weeks. 4 weeks off of work. When we do the small incisions, you're up moving around, you're never on bed rest. So when I say 4 weeks of recovery, it's 4 weeks of modified activity, taking it easy. You can still walk, you can do stairs, you can do all your normal activity, just no vigorous exercise like running or jumping. It is under general anesthesia, like most of these procedures. And sometimes there are some long-term side effects that people are worried about. So people always ask me, what about my bladder? What about sex? Is that going to be affected? The vast majority of people don't have any long-term issues after they have their uterus removed. The only thing you can't do is carry a pregnancy or have a period. In terms of bladder dysfunction, sexual dysfunction, there are a lot of risk factors for those things. Age, family history, your other medical conditions can put you at risk for things like prolapse, where the vagina drops, or bladder dysfunction, where you're leaking, or sexual dysfunction. But that's not the hysterectomy alone. There are many other things that contribute to that. So what I always tell patients is having a hysterectomy doesn't guarantee that you'll have any of those problems, and not having a hysterectomy doesn't guarantee that you won't have those problems either, because there are unfortunately a lot of risk factors that can put us in line for those issues. So if you want to be done with your periods, it's a great choice. You worried about having fibroids in the future, it's a great choice. Obviously, you shouldn't be interested in future pregnancy, and if you have other problems or concerns about cancer. It's not a good choice if keeping the uterus is important to you. If you're really young, under 35, there's some evidence that it can increase your risk of heart disease. So even just removing the uterus can decrease some hormone function that some studies show is linked to an increased risk of heart disease. That association is not significant for people who are over 40 or 45. So it's mostly a concern for people who are younger. When we remove the uterus, we are not removing your ovaries. Your ovaries, as Dr. Duncan taught us, is what produces your hormones. So you don't need to be on hormone replacement, you don't need to take any supplementation. You still got your native ovaries, they're still doing their things. So it's really only for people who are very young who might have that association. All right, so some things that we don't recommend. There are some treatments that are used in other countries or in some centers that really don't have a lot of good data. So when patients come to me saying, look, I saw this study in Europe, I say, well, unfortunately, that medication on the top, ulipristal acetate, has a lot of complications with the liver, and that's why we don't use it here in the US. So there may be some things that are good to know aren't recommended. As far as supplements, I am totally with Tanya. Wellness is really important. Good diet, exercise, vitamin D supplementation, always great. But they may not be enough. And if they're not, we now know there are a ton of medications and surgical options available. The reason we're here today is because we believe that knowledge is power. And sometimes it's really overwhelming when you go to the doctor's office and they go through this list of things. So what I go through with patients is not only these are all of the choices, but which is the best for you based on what your priorities are. What are you worried about? And that's how we figure out the choice. It's not just giving you a menu and saying, here, you pick, right? You came to me, but I'm not gonna tell you what I think is best for you. I'm gonna help you decide what you think is best for you, because you know your body best. So if you tell me, the most important thing to me is getting pregnant, we're gonna spend a lot of time talking about myomectomy, because the science says that that's a really good choice. I'm definitely gonna bring up the other options, because I don't want you going online and saying, well, she didn't tell me about that. We're gonna talk about that. But I'm gonna tell you why I think that myomectomy is gonna be a really good choice. If you tell me you're really worried about surgery, you don't want to go under anesthesia, it freaks you out, maybe we'll spend a lot of time talking about medications. So it's helpful to know what your priorities are and what you're worried about, because it helps you sift through this big menu of choices. If you don't like what you hear, if you're not comfortable with that plan, find a fibroid specialist. You all heard about from Tanya how important it is to find the right match, right? Go through 4 doctors, go through 5 doctors. I tell patients, don't hurt my feelings. If you see someone else after me, that's okay. What's most important to me is that you feel comfortable with your treatment and you're well taken care of, and you trust the person who's doing whatever they're doing. So, find someone who you feel good about. All right, it's a lot, right? Fibroids are really common. If you're in this room, you know someone with fibroids. 8 out of 10 people have them. So if you have 10 female friends or 10 female relatives, 8 of them have fibroids. As Dr. Duncan said, not everyone needs treatment. We didn't talk about watchful waiting, because when people see me, they're usually done with waiting. But that's okay. You don't necessarily need treatment if you have fibroids. It's just important you know that there are options out there if you do need treatment. So fibroids are common, and for some people they can cause menstrual issues or bulk symptoms like bladder and intestinal issues. The diagnosis is made with a combination of history, exam, and imaging. Like Tanya said, I don't have x-ray eyes. So I'm not just going to do an exam. We're also going to follow that up with some supportive imaging. Your treatment plan may include some additional testing, like doing a biopsy or blood work, and there are many options for medications and surgery. All right, I have the distinct pleasure of introducing Mrs. Andrea Leps. Please give her a warm welcome. She is very bravely going to share her story, and we are so pleased to welcome her and her husband, Wayne. We welcome your questions. To get us started, Andrea, if you're comfortable with telling everyone, how long were you living with these symptoms, and what was it that sort of made you finally seek help?
I have no idea how long, but I know I've experienced heavy bleeding, the discomfort for years, and I want to drop this real quick. As believers in Christ, for those of us who pray and fast, I did all of that. My husband will tell you, I can stay in this room for 3 hours and still be praying. Some of you may be sleeping. I did it. But the Bible also talks about wisdom. So I had to use wisdom. After everything failed, not knowing how long I've lived with this, lay hands, pray, felt something moving, I had to go and seek help. I discovered the fibroid in 2021. So I may have had it 10 years, 15 years, I have no idea.
Thank you, Andrea. We're really appreciative of you coming and sharing your story. It's very brave. There are no more questions from the audience. Would you like to tell them, a single piece of advice or wisdom? Question. Yes, Miss Pink.
My primary care physician and my gynecologist, they actually work together, because the girlfriend talk is what happened in my situation, because I had a brain situation going on. I lost my husband, and I was stressed out about that, and we were having a girlfriend conversation, and I was double packing down here, and I was on a cane, and I couldn't walk. And I told them what was going on. I was telling my besties, and they were looking at me like, what? This was 2 years of this. And because I told my besties, and she called and made the appointment with her gynecologist. And when I went, she's like, oh my God. And she could hardly do the exam. I was in that much pain. And she even the hysterectomy with everything that was going on was not her first option for me, and I ended up having to have one. But because I had waited so long, one of the fibroids had wrapped around one of my ovaries, so they couldn't save the ovary because it was grafted to it. And so what should have been a 4-week recovery ended up being a 6-week recovery, and we laughed because when I got out the hospital, I was like, where's my cane? Somebody took my cane. And so I was just echoing everything that you ladies said, even partnering physicians work, having conversations work. I take care of everybody else, but I wasn't taking care of myself. Please take care of yourself, ladies.
Yes.
I was just wanting to add on to what you were saying, because I think one of the things that we talked about with folks at the White Dress Project, this concept of watchful waiting, and that's why we liked what Dr. Ahunti said, is that there is something you can do, and once you know you have fibroids, you have to stay on top of them. So when I had my first gush in 2014, and nothing was showing, if you will, so I'm not sure how large it was. But I had my surgery in 2016, and it was 16 centimeters by then. So the growth was rapid, and so again, once you have that, just knowing that you have fibroids allows you to make the appropriate decisions, but you have to know, and that requires you to have the conversations with your healthcare provider. And then, so I just wanted to, in terms of watchful wait, it is active surveillance. You can't just kind of, we'll see if, what my partner on the White Dress Project Research Committee, she's an interventional radiologist, and she says that, this is the only condition that we say, you have it, but we're just gonna wait and watch and see what happens. Wait till it gets bad. So it really is important that you know, so if you see those changes and you, like you said, take care of yourself. You are the best judge of what's going on in your body. And you're the only one who's going to be able to tell the doctor what's going on. So you have to have those conversations. But yeah, your girlfriends, your besties are also important.
So I had a question, and it was about cost. So I know for myself and my fibroid journey, the reason why I kept putting it off was because of cost. I was a home health nurse. The place where I worked didn't offer insurance. I didn't have tens of thousands of dollars to pay for surgery. And so by the time that I got my surgery, it was at hysterectomy moment. Like there was nothing else that could be done. And so I guess my question to you guys is, do you guys know foundations or things that can help other people that may be in similar situations to where they need the help but literally can't afford it?
I have a couple of hats that I wear. So in terms of just strictly medical care in hospitals, there's many times there are options for you that a lot of people don't know about with hospitals, where they have different community options and things like that. So, well, I'm just saying, I'm gonna go sort of up the levels, right? So sometimes you have to ask, and you have to ask about, so particularly with insurance, cash payments and things like that, there are options that can make it cheaper. I'm not gonna say it gets free. In addition, one of the things that happened with my cousin actually was that she was told that she was 34, and her insurance company said they would pay for a hysterectomy but not for a myomectomy, and she wanted to have children. So she worked with the office manager to, apparently it was a coding issue. So if you know anything about that is a whole other sort of discussion. We have a whole discussion we have at the White Dress Project. So that's kind of within the, okay, so you're working within the system, if you will. So then when you get into anyone that will help to cover expenses, that becomes an issue. So patient advocate, and so one of the things you can do is to have very detailed conversations with insurers. Now, that's a long process, and as we're talking about, you want to get it done, right? So the other issue, to be honest, is that some people are not insured, and so that's a whole nother thing. So one of the things that we're doing in the White Dress Project is to try to find ways in which we can partner with foundations. So again, similar to the act that I was talking about, there's not a lot out there in terms of research dollars that are being put, and similarly, what you're looking for, there's not a lot out there either. So we're trying to find ways that we can have either events or other, and also bring physicians in who want to. I mean, lawyers do pro bono work, and I'm not gonna say it's bono because I know both. It's costly, but finding ways that we can alleviate the costs in some way. But yeah, there's a lot of factors involved. So working with either a patient advocate, or if you can find someone at your insurer, or based on the hospital system that you're in, to really work with you. But that's going to be what's required. The social workers too at the hospitals can be of use. I know I've had some challenges. My sister actually experienced a lot of stuff. So there's not a good answer to your question, I guess, in short, but we hope that we can. And we're always looking for volunteers. So if you want to help make that a reality, part of the White Dress Project is that someone with fibroids said, we need community. She started this organization. There are many things that, many ideas that come up that we want to pursue, but as an all-volunteer organization, what we need is people and time.
I want to go back real quick, Dr. Louis. I have a primary care doctor. My husband will tell you, I never miss my yearly. I've done everything. But yet, he did not discover my fibroid. And so I said to my husband, I have no idea what he did, but he missed it. I started having symptoms of constipation, gaining weight, a whole lot of other things. And I decided to go to another physician who sent me to have some tests done. And that's how I discovered there were fibroids. So there are times you even have to go to the second opinion of, you may have a primary care doctor for years, but it's okay to go to someone else. I just wanted to add that.
Hello. I have several questions, and you can answer the ones that you're most comfortable with. Okay, so the first one is when does this start? Like, is it an age group? Does it fall in when you're like 40-ish? Or kind of give us a kind of a characteristic. And then the next one is, is there any factor of like hormone imbalancement? And because I've been hearing, do you want to preserve your uterus and so forth? Does it affect people who want to have children most likely? And then the last question is, Tanya, you mentioned studies that's been done on relationship between societal impact like racism and microaggressions. Has there been studies on the effect of technology as it pertains to our bodies? Like, for instance, we know that crew workers are now radiation workers because technology has been shown that people who fly a lot will be impacted by technology. You know what I mean? So, meaning radio frequency. So, those are some of the questions I have.
We're going to tackle this probably as a team. But thank you for your questions. I think the first question you asked just about when does it start. Everybody's a little bit different, but it is women who are childbearing. So as early as you can have your period up until menopause. But there are studies that show that the rate increases as you get closer to menopause.
I was going to add to that, two of the additional risk factors that go into that is, I believe the number is 12 years old. If you have your period before 12, you're at higher risk of getting them. So again, likely it's related to the fact that since your period of time that you have started much earlier to be sort of at risk of this, then you're going to have that. So your question to me was around the technology, and I want to make sure I understood it. Are you talking about the technologies with respect to the procedures or generally lifestyle and
No, I'm
environment?
talking about devices, like the actual devices, being on devices, there is already, I worked in communication, so I know that technology affects our bodies. I'm just asking, has there been studies to show that the devices that we use commonly every day, that sometimes, you remember, there was a time in the 90s up until 2000, people put devices on the side of them,
Yes.
you know, right by their.
Or put it in their bra.
Put it in their bra, put it on their butt. On the earbuds.
So we'll cover some of that when there's kind of a broad set of environmental factors that I guess I probably won't go into them now. I'm gonna tell you to come to the What the F next Thursday, and because we're gonna do a forum where we're gonna present on some of the lifestyle things, and that includes actually environmental things. So some technology stuff will be in there. Again, that's a broad category, so I don't want to. But when you talk about, I know a lot of people will tell you, oh my gosh, 5G, don't get a 5G phone. It's, there's some overkill to that. However, if you are a worker working on 5G towers, there are some risks involved in that. So again, that's a broad topic. If you can't attend the What the F, they are available on YouTube afterwards, so it's always going to be available to you. But we'll cover a broad range of those, so hopefully that will answer your question. Just generally, I think though we are constantly exposed to things, so however you can minimize because to be honest, whether it's technology or whether it's some of the endocrine disrupting chemicals in the makeups that are out there, nail polishes. So there's a range of things, particularly for women, that can increase your risk and affect your hormones that can play into not only fibroids but other sort of hormone-dependent conditions. So was that all of your questions? You asked a lot there.
Here's one.
Oh, I just want to see if we answered all of hers. But you're ready. Okay. We're good.
I just want to say, I'm at that stage now where I'm going to have to have a hysterectomy because I had fibroids when I was like 48 or almost 50, and I had them taken out, but now I have a prolapsed uterus. So, and I have fibroids grow back within there. So they don't hurt or I'm not in pain. I don't have no periods anymore, so I've gone through menopause, but it's prolapse. So now I've gone to a doctor, I've gone to specialists, but what I want to know is, since Mayo Clinic is kind of the best hospital, how would I be able to get my insurance to pay for it at Mayo? Or I have to do it at my hospital. I have in Mayo Hospital in my insurance, but I have insurance to cover all this, but I'd like to do it at Mayo. Would I be able to do that, or no? Because I want a good doctor to do this, and I want to have it there robot done. I want something less invasive. I'm sorry. Can you guys hear me?
Yes.
Do we need to repeat it?
The question for those who couldn't hear was essentially for people who are interested in going to Mayo Clinic, how do you know your insurance is contracted? How do you know you can actually get care? The best way is to have your doctor place a referral to Mayo Clinic. We partner with all the major commercial insurances, Blue Cross Blue Shield, Aetna, Cigna. I see people with all different kinds of plans. So have your doctor place a referral. We also accept self-referrals. So in your little goodie bags, there's a little card with my number on there. That number is so you can call us and you can speak to someone from our team and get those questions answered. We'd love to take care of you. We absolutely can give you lots of different options. And part of our consultation is figuring out what we can do to help.
Hello, everyone. So this is in regards to the medical portion. So from my experience, living here in Arizona, I went went to 3 different doctors. Of course, there was no doctor that would provide the service that I needed. I wanted them all removed. If I'm going under the knife or have to have any type of major surgery, I need it done, and I wanted it all removed. Not some, not a portion, not 1 or 2, but all. So I had to do my research, and that is just what it boils down to. Honestly, you have to do your research. If you are unable to find a doctor here in the state or wherever you're located, you can also look outside of the state. One thing that I did was, because I'm from Chicago, I live here in Arizona, I couldn't find a doctor here, so I went outside to back home, back to Illinois. And I reached out to my insurance, called the number on the back of the card, and I asked, hey, is Dr. So-and-so covered under my insurance? And they were. So I had to pay, of course, to get there, but it was well worth it. They were able to remove all 31. Well, the study showed 6, but they removed all 31 fibroids. So check with your insurance card. Do your research, find a doctor that you are comfortable with. Even if it requires you to travel, go to the consultation, make sure it's something that you're comfortable with before going under the knife or whatever procedure that you decide to do, but it is possible. Another thing is also during the enrollment season, making sure that you're choosing the right plan. You got to cover that doctor. Also with the medical portion too, from what I understand working in insurance is that sometimes your doctors may be covered and within network, but not the hospital. Okay, so that's another thing you want to take a look at too. So just doing your research, but finding the doctor that you're comfortable with, going and having that initial consultation to make sure you get a feel of that doctor, that location, and then also making sure that they're covered under whatever plan that you're with. And if they are not, make sure that you are enrolling in a plan that is available to you for that upcoming season. So those are things that you definitely want to look at. So, God bless everybody.
Thank you so much. Everything she said, exclamation point, exclamation point, exclamation point. And when you're talking to your doctor, I mean, to this point of, she knew exactly what she wanted and she was very vocal in advocating for herself. One of the pieces of research that you want to do with a doctor, there's one level is of course your comfort, which we've all kind of agreed to. But the second level is the experience. Because if, what Dr. Blue talked about in terms of a fibroid specialist, right? Someone that this is what they work on, right? Minimally invasive. If you want minimally invasive surgery, make sure that they have done the work in that area. And I'm gonna say something that may be provocative to some, is I heard a couple people say hysterectomy I was at the point where hysterectomy was my only option. If one doctor told you that, you should get a second opinion. If that's not what you want and you haven't talked it through, because I do challenge, as she was told, no, we can't get them all. That was by one person, right? I was told by that first lovely doctor that, hysterectomy was my only option at that point because of the size of my fibroid. It wasn't. So again, you have more options usually than you think. That's not to say that there isn't a point where, hysterectomy is the best option for you, but, please understand that that's part of that research and that push if that is something that is not aligned with your needs and preferences.
In 2005, I was diagnosed with fibroids, and I was having a heavy bleeding. And I had a procedure done, what do you call it, ablation. I had that did. if you did happen to get cancer, that it couldn't be detected. So is that true?
That's a great question. So when we talked about the ablation, what she's referring to is the procedure inside the uterus, where we're ablating the lining of the uterus. So not fibroid ablation, but uterine ablation, where we're destroying the lining of the uterus. We talked about sometimes when we do that, there's scarring that occurs inside the uterus. And for 10 to 15% of people, that scarring can cause ongoing pain. Well, also for a segment of people, if there is cancer that grows inside the uterus, one of the ways we diagnose that is with a uterine biopsy, like Dr. Duncan said. And so if that biopsy can't get into the uterus because of the scarring, then we might miss that diagnosis. So one of the criteria for people getting that ablation done is that they're a low risk for cancer. They don't have a lot of those risk factors. So it's not that we can't diagnose it, it's just that sometimes our traditional biopsy techniques might be limited because of the scarring that occurs inside the uterus when we do a uterine ablation. So that's why some people might choose to do the fibroid ablation, because instead of ablating the uterus, we're ablating the individual fibroids. We're treating the individual fibroids. So it's these little nuances that can be really helpful when you're talking to a fibroid specialist. And I do want to highlight what Tanya was saying about, what is a fibroid specialist? Like, we've talked about that a little bit today. Like, what does that really mean? To me, that means someone who focuses on fibroids. It's not a hobby for me. I don't deliver babies. I don't do annual pap smears. I see patients for fibroids every day. I do fibroid surgery 2 to 3 to 4 times a week. So I don't spend any time doing anything else. I love fibroids. I love taking them out. So you want to see someone whose job it is to take care of fibroids, because those are the people who are going to take care of 31 fibroids. Right. Those are the people who are going to tell you, you don't have to have a hysterectomy if you don't want one. You have many other options, right? The techniques that we talked about here, not even all offices offer them. Some people say, well, my doctor never talked to anything but about a hysterectomy. It's because they didn't have the technology, the fibroid ablation. We use these technologies to offer patients alternatives to hysterectomy all the time. So, your doctor may be your doctor for a long time. They may be a great doctor for your breast exams and your mammograms and your paps, and that's great. They might have delivered your babies. That's wonderful. But maybe they don't do a lot of fibroid surgeries. And maybe for your fibroids, you need to see someone else. So that's when we can help you talk about what that something else is.
I just wanted to add to your question about the endometrial biopsy. If they cannot do it in the office because there's a lot of scar tissue, then there are other ways that we can investigate further with a hysteroscopy, that camera inside the uterus, and then we can take, normally this is done while you're asleep, but it can be done in the office. And that way we can get a good look at the lining and also directly targeted sampling to make sure that we're definitely ruling out any risk of cancer.